Good morning, respected sir and my dear friends. Today we are going to discuss about some important blood culture isolates that we obtained last week and the follow-up of that cases. First case, the patient was a 65-year-old male presented with fever and cough for 5 days duration. The cough was productive with a yellowish sputum and also having history of loose stools for 1 day without blood stained. And he had a history of COPD on meter-dose inhalers for last 10 years and history of diabetes mellitus for 12 years on OHA and hypertension for 10 years on antihypertensive, on regular antihypertensive, and had history of core pulmonale and dilated cardiomyopathy detected 1.5 years back. That time the patient got admitted for treatment for that part. And he had a chronic smoker for 40 years and he used to smoke 10 cigarettes per day and stopped 5 years back. So now he is having peculiar respiratory symptoms, fever and on day of admission the patient was tachypneic, severe respiratory distress was there, severe respiratory acidosis was there, patient was not conscious in the emergency. So this is on the day of admission you can see the RFT. I particularly took that RFT why because the patient is having respiratory symptoms, that is, and had a history of COPD also. In this age we have to calculate the CARB scores because some respiratory involvement we have to roll out some community pneumonia part. For that we can use various indexes like CARB 65 score, pneumonia severity index and all. So CARB 65 is a very friendly index that we can use, that is consciousness of the patient we can assess, and urea level if it is more than 7 millimole per liter or more than 19 milligram. You can see the urea level is 100.8, so it is definitely elevated. And the respiratory rate we can calculate, that is in this patient tachypneic, already the score is 50, and this hypotensive part, that is a blood pressure less than 90/60 is also one criteria. This patient age is 65. So if it is more than 65 it will fit. So this patient definitely the score will be more than 3. If the score is 0 and the patient is stable, no tachypneic, no acidosis, we can give OP treatment like amoxicillin plus atypical coverage also we have to give, azithromycin and doxycycline we have to give according to patient. If it is score 1 or 2, patient requires IPD management, that we can admit in the ward, we can monitor and give the IV based therapy. IV beta-lactam antibiotic with the macrolide or quinolones we can give. And the other, this patient the score is 3 or more, so definitely need ICU treatment. So the patient admitted in our ICU. So these are the antibiotics they have started because 1.5 years back the patient had history of hospitalization for the core pulmonale and he had a hyperinflated chest due to COPD, MDA, that is steroid use is there, diabetic patient, so high risk is there. So they had started meropenem. And one more thing you can see, metronidazole also they have added, that is a double coverage they have added, redundant antibiotic they have used there, and azithromycin for atypical pneumonia coverage as empirical therapy they have added. This is a chest x-ray on day of admission. You can see the right side of the lung, the middle lobe and upper lobe involvement and consolidation patches are there in the chest x-ray. So see these are the next day x-ray. It was also the entire right part of the lung is involved in it is a progressive disease, that is pneumonia part is progressive, patient having severe respiratory acidosis and the sepsis features is also there. SOFA score is matching. These are the CBC parameters. On 24th you can see the total count is about 14,000 with a neutrophilic predominance of 81%. On 27 it again elevated to 22,000 and the procal level also elevated about 24. So we got blood culture from this patient because the patient is having pneumonia, definitely one focus is there, and SOFA score is also 50. Patient admitted in ICU but there is no, when patient was not ventilated and they had sent the blood culture. Blood culture flagged on the second day, both samples flagged. In gram staining we got gram-positive cocaine chains. So this is a direct sensitivity because this patient is having pneumonia features also, so we have suspected streptococcus pneumonia, so DST is also put. This is a final report. You can see the BMQ bar MIC of penicillin G, it is coming to be resistant in this case, and in this DST the ampicillin is having somewhat shown, but the MIC it is less, only the penicillin compound came resistant, and the ceftriaxone, cefotaxime, levofloxacin and other antibiotics are susceptible to this case. So this patient, the antibiotic changed from meropenem to ceftriaxone and levofloxacin was added instead of azithromycin. So this only we have advised, that is ceftriaxone 1 gram IV BD or 2 gram you can give, and levofloxacin 750 mg because it's a respiratory fluoroquinolone. So they have changed the regimen, that is Miro and Metro they stopped and they changed to ceftriaxone and levofloxacin for this patient. So this is a recent paper published in BMJ on 2025 September. That is in India, different part from various invasive and non-invasive infection we are getting Streptococcus pneumoniae. Now the vaccination, the pneumococcal vaccine is included in the national immunity schedule also. The child are getting vaccinated, or the patient more than 65 years with risk factors, or 90 to 64 years with any risk factors like splenectomy or chronic smokers or alcoholic patients or any ear infections, cochlear implant, like that cases we have to give vaccines. So even though we are giving vaccine like a PCV 10, PCV 15, PCV, PPSV 23 like or 20 vaccination, there is some emergence of newer strains causing invasive and non-invasive infection. So this study is from India. The study mainly done in Bangalore. They have taken 254 isolates from the non-invasive and 256 from the invasive infection like meningitis, blood and all. So they have done the whole genome sequencing of all the isolates, and peculiarly they have detected 19A, 19F and 9V strains which possess increased resistance to penicillin and other antibiotics. So that emergence of resistance from various strains they have studied, including the vaccine strains are coming under this peculiar study. So in this patient, the patient is 65 years and the patient is having COPD, some risk factors is there. So when to vaccinate is another question. So if this infection is subsided with the antibiotic, after the recovery we can advise this patient vaccination. So in adult vaccination mainly we can do PCV 13 followed by PPSV 23 within a 1 year period, or either we can give PPSV 23 alone. That kind of vaccination we have to give the patient to prevent the further coming events in these risk groups. This is about vaccination. And the vaccination efficacy, PCV 13 have a vaccination efficacy of 60 to 65% and PPSV 23 have a efficacy of 73 to 75%. This is about the first case. Coming to the second case, this is actually a case coming under the study of our registry. So this is a 54-year-old female with history of morbid obesity, and steep studies correspond to obstructive sleep apnea features. Patient is having type 2 diabetes mellitus, uncontrolled DM for more than 20 years, and hypertensive and decompensated heart failure features is there. And recently the patient had detected to have hypercortisolism from outside, that is a cortisol level was increased. So they are suspecting some carcinoid or any other paraneoplastic syndrome associated with this hypercortisolism part. So they are doing this low dose test, high dose test, like that they are ruling out. So the patient is having heart failure features there, pedal edema is there, IJV is elevated, and mild pleural effusion is there, polio overload symptoms are there, poor GCS, patient got intubated and admitted in the ICU, and a central line was put. So after putting the center line, initially you can see the counts are around 10,000 only. So after 23 it is 10,000, 24, 25 the counts are little bit elevated. So the center line site was, actually they put in the femoral line initially. The site was not clean, some pus and oozing was coming from that site. So they have sent the blood culture and sent the procal little bit elevated, and SOFA score is elevated from the baseline. So both the samples they had sent from central and peripheral line. So in our lab, the second day the central line flagged first, then the peripheral line also flagged. Both Gram-Stein GNB came. So this patient is having SOFA score and the other sepsis features with underlying heart failure. There is a perfect case for this thesis case and all. We put this for biofire film arrays. This is a chest X-ray of this patient. Patient is having peculiar volume overload features is there, pulmonary edema features is there. So this is a biofire film array picture of that particular blood culture isolated from the central line sample. It's a resistant strain of Escherichia coli having this NDM and OXA positive detected in blood culture. So initially they have started this patient on piperazine tazobactam only, because on the day of admission Pakka heart failure feature is only there. So when we informed, they checked the femoral line site. It was unhealthy, completely unhealthy. Some oozing was coming from that particular site. So that is the source of infection in this patient, because femoral line is there. So there is definitely some fecal contamination or something during the femoral line care is improper. There is high chance of getting infection. So they changed from the peripheral line also. Second day we got the same E. coli isolate. So the source control was done. They changed the femoral site, clean it properly, properly, daily cleaning is done at the site, and put the IJV, right IJV they placed. So this is a blood culture report. You can see it is a carbapenem resistant strain which is synergy is coming positive. So they change the regimen from piperacillin tazobactam to ceftazidime avibactam. Here the patient RFT, when we are looking, there is the creatine level is little bit elevated from the day of admission, 2.3, in between it come to 3 like that. The creatine clearance is also elevated due to AK, definitely AK is there, cardiac failure is there. So many precipitating factors are there in this patient. So we advise the ceftazidime avibactam astrione, proper dose, extended infusion we have to give. In this kind of patients, actually we have to calculate the creatine clearance. Medcal, this online calculators are there, or Cockroach-Gault equation according to the body weight, and so many equations are there to calculate the creatine clearance. This peculiar patient, the creatine clearance, if you are putting 3.2, it is coming around 34. So you can see in this 31 to 50, we have to give 1.25 gram. Like that we have to give over IVQ8 hourly. So this is a problem in giving this antibiotic because it is coming under, we know ceftazidime 2 gram and avibactam 0.5 gram. So yesterday I went and see this peculiar patient and I asked the nursing officer how you are giving like that. So in this prescription they have written as 1 gram plus 0.5 gram IV TDS. So the nursing officer, she is telling, I can't able to reduce the dose, how I don't know. So I am giving the entire dose to the patient. So this is a thing, how we have to titrate this antibiotic in this peculiar scenario. So the patient is getting, actually it is written as 1 gram, but the patient is getting complete dose. So this is the second case, sir. So I am also a little bit confused, sir, because this preparation, how we have to titrate the dose in this varying creatine clearance values, sir.
We'll discuss that.
Sir. So that is a difficult, but because most of the times the doctor will write peculiar dose and we will mention, but the nursing officer, they are a little bit confused. They are giving extended infusion, that part they are giving, but the dose they can't able to titrate properly. So this is a second case. It's a completely case fitting to central and related bloodstream infection. That source control adequately they have done. So they are treating with the antibiotics, and the heart failure part is still there. That is ADHF, OSA and all is there. The patient is on ventilator and having some acidosis part almost corrected. Coming to the third case, this is a 19-year-old male. It's an engineering student. He presented with a fever, upper abdominal pain, nausea and vomiting for 2 weeks duration. So he had a history of travel to Chennai and took some food from outside and all. So presented with AFI features to casualty. So these are the fever chart of this patient. You can see in between some fever spikes are there, and the counts are almost 11,000 to 12,000. So the AFI, all this tropical illness panel, blood culture, everything they have sent, and the patient vomiting only, the diarrhea only 1 to 2 days only. After admission, there is no further episodes. So from blood culture, we got Salmonella typhi. From both samples, we got Salmonella typhi. So in this, I peculiarly took this case because sir has written cefixime the drug of choice and ceftriaxone is cascaded in this, and ampicillin is a drug of choice, is susceptible. So this is very important, as in our workshop also sir mentioned, even though the drug of choice for Salmonella is Harrison and other textbook, it is mentioned as ceftriaxone, and if you are testing the MIC and the BMQ when we are analyzing, so nowadays ampicillin has become susceptible because for a while we didn't use ampicillin. That may be one of the reason. And the mutation selectant window also we have to check. The BMQ is slightly, it is in this case you can see it is 1. So that's a weak cascade. If you are using that ceftriaxone particular amount, which will not cover the MSW window of that particular variant. So in this case we peculiarly mentioned. Last week also one case we discussed. That patient they changed to ampicillin and the patient recovered. So this patient also same kind of things we have reported. We cascaded ceftriaxone and ampicillin also we suggested. But this patient they have given actually ceftriaxone 2 gram IV. They are continuing that, they didn't change the antibiotic, ceftriaxone only they are continuing. Actually the patient yesterday when I saw the patient is having mild transaminitis part also. So that part they are evaluating why the patient developed transaminitis. The fever spikes somewhat okay, subsided, there is no other GI symptoms, patient was somewhat okay, but the elevated SGOT, SGPT part, they are looking, they have sent the hepatitis A, E, other tropical illness panel and all. I advise them to one more send the blood culture also. We don't know what is the cause of this transaminitis in this patient.
So and even shift to cefixime also.
Yes, sir.
Parenteral cefixime you could have given.
So this is
basically hardwired into using only ceftriaxone for salmonella typhi.
Yes. So that is a case. Coming to the fourth case, actually the patient got LAMA from our emergency itself. This is a 63-year-old male. So in this case, some improper, they didn't send some important cultures. That's why I included this case. So 63-year-old male presented to emergency department with acute exacerbation of COPD, features of corpulmonale, ADHF, anasarca, cardiogenic shock. The patient peculiarly had a history of painful micturition for 1 week duration. Patient had diabetes, hypertension and a chronic smoker also. So these are the various total CBC and other parameters. You can see elevated counts are there. Creatinine level is also elevated on the day of admission. They had sent a urine routine examination. Correctly they had sent because the patient is having typical urinary tract infection features. So it came pustules of about 4 to 5, bacteria present and nitrate positive, like that it came. But they didn't send urine culture for this patient. And these are the hospital, this patient got LAMA, this is a hospital course. So initially the patient is having definitely COPD and other features, respiratory acidosis, respiratory failure features. So they have given hydrocortisone, they have started piperacillin tazobactam, that is creatinine level is somewhat elevated. So 2.25 gram with the clindamycin they have given. So pulmonary opinion they have taken, again you can see the dose difference. Piptas, the pulmonary people, they advise 4.5 gram. Then patient is having bilateral cellulitis also along with anasarca. So surgery opinion they have taken. They have written cefuroxime 1.5 gram 12th hourly. And nephrology opinion also they have taken. They have written meropenem clindamycin. So different opinions regarding each and every consultation for this patient. But this is blood culture they have sent from this patient. You can see that serratia from the blood culture and blood agar and McConkie agar, both samples from this patient we got serratia marcescens. So this serratia, what is the source? Maybe probably the urine. That because the urine culture they didn't send to our laboratory, urine, the pustules, everything is favoring. So cellulitis is there because it is rarely serratia may cause cellulitis. It may cause sometimes, but it is rare. So the patient got discharged. We got serratia. This is a final report of this particular isolate. It is substitute to piperacillin tazobactam, cotrimoxazole, aminoglycosides, quinolones and all. So we particularly mentioned about the intrinsic resistance, spice organism, everything regarding the serratia. So in this case, what happened is this patient, after taking proper history, they have taken everything they have taken. They look at the blood CBC, RFT and all, but different opinions because they are not correlating with the each and every these consultations and all. The patient finally got, I asked them, the resident, he's telling he got PIP test, the first one only patient got, and patient got a LAMA from our hospital. And one thing is they didn't send the urine culture of this patient, even though that peculiar urinary tract infection features is there for 7 days. Patient is
Medicine department.
So, emergency only came, sir.
Emergency went from there.
Yes, sir. So that kind of things happen to this patient. So the serratia from blood, maybe it's a case of urosepsis we are thinking, because from urinary tract only the patient is having diabetes mellitus features is there and having clinical features of UTI for 1 week. Maybe the source of infection may be urinary tract. So this is our report. We clearly mentioned about the spice organism inducing AIIMS by giving this amoxiclav, imipenem like combination induces intrinsic resistance, everything we mentioned in this culture report. So this all about the 4 cases.
So we didn't have any follow-up on the antibiotics given to this patient?
Only patient got LAMA, sir, but he had received Piptas 2.25 with the clindamycin 300 mg.
In the emergency?
Sir.
Okay.
Thank you.